So do you think we should start?
I think whenever you're ready.
Well, maybe we'll get started. I know people have things to do, and I want to be respectful of time. So I've got people here in the room, which is wonderful. And then there's people watching on Zoom from, I think, around the country. So shout out to those people. I wanted to start by just thanking the International Education Week for having me be here as a speaker. And I thought what I'd do is just talk about some of my experiences globally. I know that a couple of the students here might be going to some of the places I've been to. So I'm open to questions. Please interrupt me at any time. I kind of thought that I'd take this as just like an experience. And with any kind of an experience, even talking to you right now, there's things you bring into the experience and things you bring out of. So that's kind of how I've geared this talk, is just some of the experiences that I've had, the things I brought to them and things I brought out. I'm going to show some photos, especially some photos that mean a lot to me. And excuse me ahead of time, because with this mask and also just my ability, my inclination to sound like I'm crying. I'm not really crying, but the mask makes it sound like that. So don't get out your Kleenexes right away. I'm also going to be telling a few anecdotes, which is part of narrative medicine in a way, and whether that's helpful or not, I hope it's helpful. I've learned a little bit more about anecdotes and narrative medicine since I've been here, so please be open to it, and welcome to more people here. These are the places that I've been. Zambia in 2008, which is almost 13 years ago. I spent a month there. Then I was in Punta Gorda, Belize, which is in the southern part of Belize, and I'll tell you more about where that was. I was there for 18 months as the medical director in 2016 and 2017. Then I went back as a preceptor in 2018 and again in 2019. I also worked in Tijuana at the border for about a month in 2019, and then also again in 2020, just before the epidemic started. And then I've been in Des Moines. So this is kind of what we're going to talk about today. And as I said already, what I brought to the experience, what I left with. So the first place was Zimba, which is in the southern part of Africa. You can see on the map there, it's not quite as low as South Africa, but it borders Zimbabwe. You've probably heard of Victoria Falls, which is the widest waterfall in the world. Where I was in Livingston, which is, if I can get the pen to work, right down here is Livingston. And no, I can't get the pen to work. So it's right along the border. And Livingston was named after David Livingstone, a colonial explorer. So in my class, and I didn't mention this, but here at Drake, I've taught this class called Topics in Global Relief Work. And we did talk about colonialism, and especially in the field of field work or mission work, that there's still some colonization of centers that people go to. So there's an element of trying to decolonize global relief work. But that's where I was. And the reason I went was to relieve these two people. This is Dan and Joan Jones. They were partners of mine where I worked in Moorhead, Kentucky. My family practice is in Eastern Kentucky, and these were two of my partners there. And they had been working at Zimba in Zambia for 5 years, and they'd never been able to take a break. So this was their chance to go to a conference, and they needed somebody to cover. So I went down there for the almost 4 weeks to cover them. So what I brought to that experience was my clinical skills, my medical skills, which I presumed would be helpful. I've came to find out that the Western skills of a medical doctor are not always the perfect thing for a place in Africa. And then I had the sense of purpose because I thought I was going to be helping the hospital cover while these doctors were gone. My fear, and I'll tell you each time, my biggest fear was I didn't even know what to fear because I didn't have any idea. I didn't really have any preparation. And unfortunately, when I got there, because I was covering for them, they left about an hour after I got there. So I had a tour for about an hour. So not ideal. And I think it reflected in my experience as well. So this is, you can see in the bottom photo, the Zimba Hospital from a distance. It's pretty basic building. From a bit closer is the actual grounds. On the left side are the adult wards. There's another L-shaped alcove that was the pediatric ward. And then where the window is open was the isolation ward. TB and HIV patients were there. And a little bit further back was where all the outpatients came for medications related to TB and HIV. And then there was another larger area for outpatient clinic patients. This is a picture of the inside of the adult ward. And this was pretty common that at lunchtime or meal times, people would just bring up their own silverware and dishware and have what I would call gruel dished out to them. I think it was probably something other than gruel, but it was delicious. I mean, it was very healthy, ground nuts and things like that. While I was there in Zambia, we saw a lot of infectious disease. I treated several babies who had been what they call HIV orphans. At the time I was there in 2008, HIV and AIDS was very prevalent. I think the prevalence of HIV in Zambia at the time was over 25%. So 1 out of 4 people had HIV, and there at that time wasn't quite the amount of treatment for it. So many infants were born after their parents had died from HIV, and they were considered HIV orphans. They also were stigmatized, so many of those babies didn't get fed properly. Even if their family members had adopted them, they were still not fed or treated really humanely. So we saw quite a few babies in the hospital that just needed nutrition and IV hydration. That was a sad part of that situation. We also saw snake bites, wounds, just your basic pneumonia. On the HIV and TB ward, there were a lot of people who had just had an exacerbation, so they were in for either antibiotics or just support to get their counts up. And this next picture is one that I've had on my wall since I came back from Zambia, because it's really instructive of the difference between Zambia and many countries in the US. This mother and her son, the mother is the one with the probably 10 pounds or more of produce on her head. They've just been released from the hospital. This is their discharge photo. So instead of being wheeled out in a wheelchair, which is a requirement in this state, in this country, they're walking, and they're probably going to be walking about 5 miles to get home. So it just reminds me every day of what a difference it is in different countries. So what I took from being in Zambia was that it was very difficult. Working in another country is difficult, especially if you don't have preparation, if it's extremely different from what you expect, or the medical field is different. So I think my word for it was just bewilderment. And I was old enough to not be just a naive child to have gone down there, but I still wished I'd had more preparation. And my next experiences were much more prepared. And I would recommend for international adventurers that they get prepared, because it is bewildering. The next place that I went to, like I said, in 2016, was to Hillside Clinic in Belize. And you can see where Belize is kind of sandwiched, well, not sandwiched, but more or less shadowed beside Guatemala, and it's just below Mexico there. And where I was down in the lower portion of Belize, the southern district. It's called Toledo. And that's where most of the Mayan population of Belize lives. We had a permanent clinic at Hillside Clinic, and this road, which is where the sign for the clinic is the road that comes from Belize City up here. And I gotta get my pen up again. The road, there's just about 3 roads in Belize, so you can't get lost there. But the road comes from up here in the middle of the country, where the star is, if you can see that, and it goes down through the countryside to almost to the Guatemala border, and that's where Hillside Clinic is located. This picture on the right, you might think, oh, look at all those roads, but those were like roads that were dirt. Dr. Rovers has been there and probably traveled on some of those roads as well. Many times. Exactly, yeah. And if it's raining, they're impossible to get across. So oftentimes we couldn't go to our mobile clinics because of them. This was a sign that was up Jaguar Crossing, and it wasn't so unusual to find animals crossing the road no matter where you were. But this happened to be at the Jaguar Preserve, which I was able to go to on a couple of weekends and camp up there. So what I brought to Belize were my clinical skills again, these medical clinic skills, and then this long-term commitment. I had kind of arranged and thought about this probably for a year before I did it. I'd gotten somebody to take my practice over as a palliative care doctor, and that took about a year. And then I was planning to stay there for a good year. I'd committed to a year, and then while I was there, they asked me to stay longer. So I was there for a total of 18 months. I brought a sense of adventure and just excitement about someplace different. And then I also thought I was going to be doing some good. Hillside Clinic, I'll go through this a little bit, is the picture on the left bottom. That's the compound, and there's a permanent clinic there that serves the surrounding area. So there's Mayan villagers who come on the bus to that clinic. There's just the people that live in the neighborhood of the clinic. It's about 6 miles from the main town and hospital. Over here on the left, you see where the kind of white panel is. That is a place called Abby's House. And if students go down to Hillside, they'll stay there. There's room for 18 to 20 students who are housed there for their 4-week global rotation. So Hillside is designed to give medical students, pharmacy students, public health students, PT students, sometimes OT students, a 4-week global rotation. So that's where you'd be staying. And then the clinic is, like I say, there in the middle. The buses or the trucks are what we take out to mobile clinics. And each day we'd take half of the team of students and 1 preceptor out to a mobile clinic. So you can see an example of that in this lower right picture. When we got there, we unloaded the trucks and put down everything we needed to hold a clinic. And we would hold a clinic for about 3 hours Again, most times it was the villagers that lived right around there. We would honk the horn as we drove into the to the village so that people knew we were there, and we were there about 3 hours every time we went. So here you see some pharmacy students. I don't think they're Drake pharmacy students, but they're setting up the pharmacy. We had Tylenol. We pretty much had anything that was needed. A lot of diabetic medicines, hypertensives, antihypertensives, antibiotics. And then we would sit in rooms kind of like this. This clinic was much smaller than, I mean, the clinic on the right was much smaller than the clinic on the top there, but we would just put out little chairs. They were school kid chairs and sit there, and everyone that worked at the clinic, and there were 26 Belizean staff that worked at the clinic, all of them spoke Quechua, which is the language of the Mayan people. So most times we would have a staff person translating, a student seeing the patient, and then the student would come to me or one of the other preceptors and find out, what should we do, talk about the case and so forth. So it was a really good system. I think the patients liked it. The government asked us to hold these clinics, and the students learned a lot, both about medicine and about culture. And speaking of culture, please interrupt me if you have any questions, kind of flying through some of this stuff. This is the staff, part of the staff that was there when I was there. As I say, there were 26 Belizean staff, and now there's even more. There was just 4, at the time I was there were 4 non-Belizeans, and we were long-term volunteers. So there was a physical therapy director, myself as the medical director, there was a nursing director, and then while I was there, the pharmacy director was a Drake alumnus. So that's the connection. And then I met Dr. Rovers, and he invited me to be this visiting practitioner. But I like this picture. It's up on my wall, or I look at it often, because in Belize, there's several different ethnicities. If you can look over here at this picture on the left side, I have to say the shorter people are all of Mayan descent. And one person on the very far left is the new nurse. She went back and got training. She's a full RN. She runs the nursing program down at Hillside now, so there's not a need for a full-time volunteer North American nurse. The next person over is Victor. He's now the pharmacist there. He went and got extra training. So I just think it's great that this program and Hillside has promoted education in their staff. It's not just a one-way, like only taking, they're giving back. Also in this picture is an example of all the different cultures. The man in the middle with the white kind of a varsity sweater, I guess you would call it, is a Garifuna. Mr. Nick, he is the director of the public health program down there. The man next to him with the hat is a mestizo. And then the others on the side are East Indians. So this is a day, they call it Cultural Day. And it's kind of like what your kids go to in preschool, where everybody dresses up in their outfits from their home countries or their ethnicities. Well, here, in Belize, everybody does that. The whole country celebrates Cultural Day, and we had the foods from those ethnicities and from their background, and it was just wonderful. When the white people, myself and other long-term volunteers from North America, we had to try and think of what should we dress as and what should we offer as food. And the only thing that I could think of was root beer floats, which actually went over pretty good. That most of the Belizeans had never eaten or had a root beer float, so it actually was pretty good. So what I learned from there was about adapting to living in another country for a long time. I mean, there's this time frame. I think in my case, it was about 2 or 3 months where everything was new. And then after about 3 months, I started to adapt, and everything was what you would expect. I mean, nothing was out of the ordinary anymore. But then about 3 months before I was to leave, the same adaptation went, the other way. So I learned how to adapt down there. I also saw how our system is probably not as good as many other health systems, especially in regards to public health. And I think that's come up even more so now with COVID-19. While I was there, I was on the surveillance committee at the hospital. So we would monitor everything within the whole country. And they were very responsive to trends like extra diarrhea in one village. And so they'd go out with their vector control and see if there was something wrong with the water, the tanks, how they chlorinate the water. And it turned out there was. The village didn't like the taste of chlorine, so they'd been cutting back a little bit on the chlorine concentration. So it was just very practical. And as a matter of fact, that what I saw about how Belize did so well with public health is the reason that when I came back to the United States in 2017, I went ahead and got my master's in public health because I just thought, yeah, this is where medicine should be, helping public health. Now the other, oh yeah, go.
I actually have a couple of questions.
Sure.
About your adventure in Belize. So first, in Belize, do they have an equivalency of a community health worker? Maybe something like a promotora?
They do. They actually call them community health worker, and each village has their own person that has been selected to be a community health worker. Usually those are people who have some prestige in the village. And then every month, Mr. Nick, the Garifuna man in the middle there, will put on educational seminars for them. So like, I know that the students and myself went one time and we taught about diabetes, how to check for sugar. Now, what I understand from talking to some of these health workers, I think they're just called health workers. I forget what they're called. Maybe they are CHWs. What I heard was that they used to do a lot more, like they used to deliver babies in the villages and they used to suture, but because of some risks, they're encouraged not to do quite such extensive things. And as medical care in Belize has improved, they've asked that people who are pregnant come to the hospital a couple of days before their due date so that they're not at risk of delivering at home.
And I guess another question, what is the role of herbal or non-traditional medicine, please?
So that's a really good question too. The Mayans particularly believe in herbal, and that was one thing that we heard of all the time. Our clinic didn't necessarily have an herbal room, but I'll tell you about an herbal room in Mexico that was a big part of the clinic there. But I will tell you a little story about Victor. So Victor, and I think you see him on the left, he's the pharmacist. His father owned a farm close to where the village was. And one day, Victor, while we were driving back from one of the mobile clinics, got a call that his father had been bitten by a fer-de-lance. Fer-de-lance is a snake that's very poisonous, and people do actually die from it. And his father had been bit by the fer-de-lance, and the father was at his farm, which happened to be right as we were passing. It was on the road that we would pass, that we drove back to get to the clinic. So we said, well, we'll stop and we'll see if we can help in some way. So Victor, I could tell he was in the back of the vehicle and he was a little bit hesitant about our help, but we drove up there anyway. We're not stopped by somebody telling us not to go. So we stopped and we started to get out of the car. And it happened to be all women. Myself was the doctor. I think there were 8. Well, yeah, there were 8 students, all of whom were women. And we started to get out of the car with our blood pressure cuff and just offering help like you would with a snake bite. And he said, please don't get out of the car. It's our tradition that after a man is bit by a snake, they shouldn't be seen by a woman, because that could lead to their demise. So we were told to stay in the car, not to get out, not to even look at his father. His father was in a hammock in the farm, just resting as much as he could. And Victor was going to bring him a poultice to put on his snake bite, and basically did all herbal medicines. No Western medicine was given to him, no anti-venom, nothing. And his father did well. I mean, he didn't do well right away, but over the course of the next 3 to 4 days, he survived. He had a large swelling of his extremity, but it was just an example of how different medicine is, and how we could probably listen to some things. Any other questions from the? So the other thing I found from living in a location for so long, 18 months, was that you do get pretty connected with people. And Mr. Rudy was one of those people. He was the driver, so all the students would ride in the vehicle every day with him. I rode in the front seat because I get car sick. So I get to talk to him all the time. And between the time I was there the second time and the next time I went in 2019, he passed away very quickly. He was only 58, and he died suddenly at home, probably from heart attack and diabetes, which he didn't take great care of. But much of the visit that I was on was taken over by his funeral. The clinic was closed, and you can see in this picture that his body was carried in one of the vehicles that he had driven so many times. So I was able to go to the wake and go to the funeral, but when you are with people like that in a setting, a global setting, you get pretty attached to them. So that was a hard lesson to learn, that, this true partnering and companionship with another country, a clinic or whatever, it hurts when you lose people like that. So the next place I went, and a most recent global experience I had, was in Tijuana, at the border of the US and Mexico border. You probably all know where San Diego is, and Tijuana is just south of that. The group I worked with was the Refugee Health Alliance, which is a pretty grassroots type of organization. It was started by just some university students, pretty much like you all, who just saw that there was a need for medical care of migrants who were coming to the border to try and get asylum. So they just started going over on Saturday. Most of them lived in San Diego or LA. So they'd take backpacks full of medicines, cross the border, and set up clinics in the shelters there in Tijuana. So just like that, an idea. No, they were pretty smart and savvy, and some had worked in other settings, but I just was very, very impressed with that. The picture in the middle is of the border and how it goes right out into the Pacific Ocean. And my partner and I went there last year, just before COVID, and we had translators. Michelle was one of the students from my home school, Moorhead's, not my alumni school, but where I live in Moorhead, Kentucky. She was a student at Moorhead State, and she went along as a translator, and her mother had crossed this border as an asylum seeker, as an immigrant many, many years ago. And she took this picture and had quite a emotional response to seeing where her mother had come across. So the other picture shows the asylum seekers, the migrants who are waiting to see if they can get into the United States, they're waiting to hear, while above them is where people who have their passports and have legal rights to cross are crossing across. So it's just such a contrasting picture of those waiting to see if they can get in, and those above them walking. And you can barely see around to see these large throngs of people. And I was always afraid to look too hard because I thought, oh, customs will come up and snap me up and say, put your camera away. But and these are some of the people. This is kind of a typical day at El Chaparral. This is the gathering place every morning at the border where anybody who was looking for asylum would go to see if their asylum number was called. It's a little complicated and it's changed a bit now, but when people arrive at the border and they don't have permission to enter, they're not refugees. Refugees who have been given permission to come to the United States usually fly in, or they have an easier time getting in, but asylum seekers just come to the border, and that's when they ask for if they can enter the country. So these people are waiting for their asylum numbers to be first assigned and then to be called. So sometimes those asylum numbers are up in the thousands and 2000s, and they're waiting every day. So every morning they'd come to this place called El Chaparral and wait to see if their number was called. In the meantime, they'd be living in these shelters, and this is just one shelter. It's, I think, one of the smaller ones. There's about 20 shelters around in Tijuana. Most are for women and children. Some are family oriented. There's one for LGBTQ persons. There's another one for unaccompanied minors. But they're basically, each tent represents a family unit. And then the final picture are the North Americans and some other nationalities who would come every Saturday to do a clinic in these shelters. So there was sometimes 25 to 50 people that would come to help out at the shelter and just put on a medical clinic. So I went down there to help with the Saturday morning clinics, and then they also have a daily clinic that I worked at too. In this picture on the right, you'll see kind of a green doors, and that was all where the herbs, there was a closet full of herbs, because so many of the people who were traveling, the migrants and asylum seekers, wanted to use herbal medicine. So that room was full of just every imaginable herb. And oftentimes we would see a patient, give them Western medicine, and then they'd go in there and actually get what would work for them. We had a midwife who was from Mexico, and she oftentimes used those herbals. So what I brought to Tijuana were, again, my clinical skills, a sense of doing something about immigration. I just heard a lot of talk about it, and I thought, I can do this. And then I felt like I was filling a need. My biggest fear, oh, I forgot to say, in Belize, my biggest fear before I went was flying in a small plane, because in order to get down to Punta Gorda, the roads are so bad. And you can't really take a giant suitcase. So I knew that I had to fly. So the planes that fly down to Punta Gorda are just tiny. So that was my biggest fear the whole time before I went there. In Mexico, my biggest fear was that I wouldn't be able to speak enough Spanish. And it turned out I didn't have enough Spanish. And since I've been here in Drake, I realized how much of a disadvantage that was for the patients that I saw. Not speaking their language really hampered my ability to give them good care. So this is a picture I have up as a reminder. And again, I like pictures that contrast. Here's a little girl who's got her phone number stenciled or written on the back of her neck. We've had some discussions about whose number that might be, whether it's her mother that's with her, or whether it's somebody in the United States that if she was separated from her mother, they could call that person. In in these proceedings, oftentimes the asylum seekers will be separated. Like it's not unheard of that a child would be separated from their family members. So, but the contrast with the Little Mermaid or Nemo, there's just, and since I've been here, again, I've been able to talk to a couple of classes, and you know, the structural violence concept, the structural violence for this little girl of being disrupted, the insecurity, where is she going to live? Her education has been disrupted as well. All of these things are just are going to affect her life for her rest of her life, and maybe even generations. As I said, Michelle, whose mother migrated across that border, I think she has some generational effects from that migration as well. So now back to, so we get to Drake. And this is my office, pretty unadorned at Klein Atrium. And when I got here, when they showed me my office, they said, oh, be careful, because when it really rains, it sometimes floods down there. So in bad flooding, I'm kind of like, oh, I hope it doesn't flood, but so far it hasn't. I don't know if anybody's seen that or not. And trying to be more academic, I've put together this table, which I've already talked a little bit about, but if you notice at Drake, I came without any clinical skills. My clinical skills didn't help me here. I had limited teaching skill because I do teach a lot of students, but more as supervisors, as preceptors. So, but what also brought me here was just a curiosity about academics. And I certainly left with great sunsets and sunrises, plus more. Any questions? I'm gonna move into a little different part of the talk. Any questions on the chat? So the lessons I've learned here from the class that I've taken is that there is a strategy for having a good short-term global service trip. They don't all have to be, you know, abandoned because they're not good. There's best practices that include language, having the person learn the language if it's not English or a language that they're fluent in. The length of time is really important. So 2 weeks is probably too short. 4 weeks is about right. Anywhere up to about a year is really good. If it's more than a year, sometimes the volunteer starts to take over. So I hope that didn't happen in my case, since I was in Belize for 18 months, but who knows? It's only my opinion right now, but I think that those two things, and then also having a permanency, you know, the sustainability of a clinic or a partnership that's sustainable is really important for any kind of global service trip. I've also learned that these narratives that I talk about, these anecdotes, how they affect public health issues is that they raise awareness, but they might not really change policies. So it needs both anecdotes and facts. So as if any of you are going into public health policy, you know, what I'm saying and different things that people testimonial to are important, but that they're not all of the picture. And then I also learned about capacity building and how some programs really do a lot of capacity building in the host country and some don't. Some things that students have asked me from being in all these classes, which I hadn't thought about as much as I would have liked, mental health. I think there's an awareness that mental health is very important, not just in the United States, but in all these other countries as well. I think that's the #1 question I got in every class that I've been a speaker at is, how did Belize handle mental health? How did Tijuana handle mental health? So for the future, we definitely need to be addressing that. I already mentioned about the language and how speaking the language and taking the effort to learn a different language is really important. I learned about perceptions of fear. What what do you fear when you go to another country? And so the students that went with Cap and I to Tijuana, they had disparate ideas about fear. So they both went to Tijuana. They're both from Mexico, their families were. One student, Jose, said his family was very fearful of the cartels, and especially in Tijuana, which is supported by what we see in the media. I mean, I think anybody who reads the paper about Mexico is a little bit worried about cartels and, you know, accidental shootings and things like that. The other student, she had no fear of that. Her family was not afraid of the cartels. She saw Tijuana as a place of hope. And it was just such a contrast between two students who seemed to have the same background, but had different ideas about fear, perceptions of fear. Structural violence, we've talked a little bit about, and the effects of that in all the settings that I worked at. And then cultural influences, which we've talked a little bit about today. And there were many, many examples of that in several of the places that I worked. So for people that are not able to travel, I'm involved with a couple of desktop involvement where you don't have to leave the country. If you want to do advocacy, we had Keith Johnson from the Fund for Global Health come, and that is a group that is pressuring Congress to spend more money on global health funding. So in particular, TB, funding for TB, and also funding for primary care and accountability with the US aid funding. So that was his talk was wonderful. And I think the students in my class learned a lot from that. The Addis Clinic is another way to help. This is for physicians, pharmacists, physicians, nurse practitioners, PAs. The Addis Clinic takes referrals from, they have a network of referrers, which are medical officers in Kenya primarily. And for patients who they have trouble figuring out what's wrong with them, they'll ask a volunteer consultant in the United States to give them advice. And while we've been here, I think we're going to start having pharmacists do that too. So, you know, for your pharmacy students, when you get out and get your license, that might be something you could do for a couple hours every month, is just give some suggestions to Kenyan medical officers, and you don't have to leave the country. So hopefully that'll get in process. The other thing for people that are speak another language is that all the legal work that goes on with migration and asylum seeking, they all need to be translated. So a group called El Otro Lado was in Tijuana, and they did all the legal work, and they just always needed translations. So, oh, I think that might be the last. I have one more picture though that I want to show. That's
And stop share so people can see you.
okay. Well, I wanted to show my beautiful sunset, but that's okay. You can imagine one of the beautiful sunsets, and they've been almost every day here. So I really appreciate being able to see sunsets. And even though that was what I feared about being in Des Moines, was the living in flat land. It turns out not that flat, and Iowa is not the flattest state by a long shot. Michigan is flatter, and although Kentucky is the second not as flattest state in the country. So that's what I learned. One other thing I just wanted to say is that I do wish I'd utilized more Drake professors for my own class, because I'm just impressed by the breadth and the depth of international work here at Drake. And I probably should have used a few more Drake professors in my class as speakers instead of all outside. But yeah, I'm opening it up to questions. I think we got a few more minutes.
So we've got a really good question. Where are you going next? What's next? on the agenda?
Yeah. That's a good question. I don't really know. I've been offered, or I've been, I don't know if the word is offered, or given the opportunity to maybe work at a Native American reservation in New Mexico. There's a group called, what is it called? ARC, the ARC, and they're kind of like a locum tenens for social responsibility. So they place doctors for short periods of time in centers or clinics or places that don't usually get doctors. So some of the Native American reservations, American Indian reservations are where it's difficult to get doctors. So there's that possibility. I don't know. I feel like sometimes you need to take a break. Throughout my career, I've kind of planned out taking breaks about every 6 years. So when you young people start out thinking about your careers, you almost have to plan it out, that you have a mindset that maybe you won't go up the corporate ladder or whatever the ladder is that you want by taking a break every so often, but you almost have to plan it out. And that's how I was able to do some of these things. So right now, I think I'm going to go home and recharge batteries and not make any commitments just right off. Anybody want to say anything about, I mean, does any of this resonate with what you've done with, I know there's a lot of people from international.
So thank you, first of all. It's just so fascinating from a number of perspectives, but culturally so, I guess, intriguing to me. One of the things that I've always been fascinated with medicine in particular, with this, with the kinds of experiences that you've undertaken, is how do you, so when you're a, let's say, non-medical professional, I'll say civilian, going into another culture, you're constantly navigating those nuances and sort of trying to understand and observe and react appropriately. And coming into these settings, you are, like you said, you're bringing your clinical skills, you're bringing a significant, valuable expertise to the culture. But like you said, in Zambia, for example, you get there and there are diseases and things you've never treated or dealt with. And that is just so fascinating in its own to me. But how do you navigate then that type of cultural, I mean, you're of course consulting, I'm sure, resources on how to treat specific things, but I'm sure you're also consulting local folks with the on-site expertise. But how do you navigate your own the own expertise that you're bringing in that cultural context where, like you mentioned the term bewilderment, where you're simply bewildered at the same time, but feeling like you don't know. Walk us through how you navigated that and what that looked like, even just from a day-to-day perspective.
Before you answer, did your Zoom audience hear that question?
Yeah, they did.
Oh.
Just make sure you're asking questions.
That's
Speak up for the crowd.
That's a really good question. And I'm going to say that I didn't do it very well. And the way I walked through it later on was just right, like realizing that I didn't know much. And North Americans and Western medicine doesn't know as much as we think we do. I guess humility would be the word. Now, I think being in Belize for that long a period of time and working with professionals helped a whole lot to see that, the outcome of something doesn't have to be what I thought the outcome would be. Like, it doesn't have to be somebody getting better. It took a long time. I do write. I write a lot. And usually when I'm in situations like that, I'll write down what I'm thinking and then I come back to it later sometimes I'll even publish them. So I think the writing helped, but on the spur of the moment, I become just as defensive as anybody else. And I don't know if I'm going to get better with that with time or not, but I hate to say it, but I don't think I have an answer for you.
No, I think about a lot of times, different cultures have very culturally rich ways of treating something or dealing with something. And then, you're maybe coming in with a completely different approach and just how you negotiate, your own beliefs versus their cultural beliefs and how, I find that to be so fascinating to think about. Just even, like I said, from a day-to-day on the ground, you're constantly negotiating those cultural belief systems and nuances in a obviously much different way than at the grocery store. I mean, it's in people's lives.
Right.
It's just so, I'm sure, so interculturally challenging, but also just very enriching.
Yeah. And I think, again, part of my mission here was to educate students. And I think Hillside did a really good job with that because we would encounter cultural differences on a daily basis. But every evening we would sit down and reflect on, or at least by the end of the week, there'd be a whole several hours spent on reflection. And I remember a case of a woman who had a black foot from diabetes. And in Mayan culture, it's not, people can't go to heaven with one of their appendages missing. So you can't get in heaven if you have had an amputation. So this happened 2 times, two separate women, Mayan women, who had diabetic foots that their foot actually turned black. And they were going to die if they didn't have their foot amputated. And for one, the woman died. And for the other, some extraordinary efforts by a PA student who was there saved her foot and saved her life. But, the outcome that we as medical doctors and maybe Western medical doctors would be that she'd get better and live. But for her, she would prefer to die and go to heaven. So just what you said, we have such different cultural expectations. Yeah, good question. Any other comments or questions? Yeah.
If you had to choose someone to go back to or someone else to go,
Well, that's a good question too, because I just yesterday got a request from Hillside. They need a medical director again for 6 months. So I have to decide if I want to go down there and from May till the worst part of the year, May to October. It's really hot there. I think that, I don't know. I now know that I need another language. So I'm limited to English speaking. I don't really have a desire to go like far-flung place. Between these adventures and just traveling, I've been almost everywhere, Alaska, Europe, you name it. So I don't really have a strong desire to go far-flung. So I think now I'm going to concentrate on our nation and some of the indigenous or underprivileged people in this country more than outside of the country. So I guess I've come 180 degrees when people ask me, well, why aren't you staying in the United States and help people here? And I said, well, so now I've come like 180 degrees around to, yeah, maybe I'll just work here someplace. Are you interested in global work? Yeah, it's you gain so much from it. I mean, I would highly recommend making some sort of a trip or have some sort of an experience if you possibly can. Any other questions?
I think one of the criticisms of a lot of this sort of medical mission work, for lack of a better term, is that it never deals with the underlying problems, which are usually poverty and quality of governance and driving a lot of these problems. But I would also offer, we don't do a better job with that in the US either. We have the same problem causing the same outcomes. I mean, do you have any thoughts as to what the role might be for looking at those more distal determinants of the problems that we see in those settings?
Well, that's an easy question. Well, I do know that we've got to get out of the idea that money is going to fix everything. You know, throwing money at the social at these social conditions doesn't always work. Yeah, equity is so important. I guess that's what a lot of organizations are working at is so that there isn't such a big gap between the poor in this country anyway, the poor and the rich, and how many resources are available to each one. But yeah, I'm at a lower, as they say, lower pay grade than knowing how to solve those big questions.
How much role do you think the quality of governance plays? Because I mean, certainly some of the places I've been, the quality of governance is just terrible.
Mhm.
And, you know, as medically trained, I have no idea how to fix that.
Right. Although, you know, some countries like Belize, they actually had better,
Yeah, they're playing elections.
yeah, right. But as far as making that a priority, especially in regards to health, that was a priority. They had a Ministry of Health that was very engaged. So, yeah, I'm sure governance has a lot to do with it. Yeah. Well, I think we're at about the time. So I appreciate you guys' attention, and I'm assuming everybody on the Zoom call was paying close attention as well. So thank you. And if you have any questions, please let me know.